So my name's Ilyas. I'm just going to run you through my systematic review, which looks at attempts to summarize or collate previous work that's been done to successfully engage men with mental health interventions. Where's the clicker? Okay, so as an overview of what I'm doing, so this is part of my PhD, which is funded by the National Institute of Health Research. And just more broadly speaking, my overall objective is to develop an intervention for male students which hopefully improves their willingness to engage with psychological support. And then in order to do this, this is split across 4 key projects. So first is to do a systematic review of previous work that's been looking at help seeking. Next is to run a series of focus groups with male students to work out what they think is important in an intervention or in a workshop that will improve their help seeking. Next is to use the data from the first 2 projects to sort of develop my own intervention, and then finally pilot it. And as it's probably quite clear, that I'm going to run you through the systematic review part of that project. So as an overview, in help seeking in general, only 36% of referrals to IAP, so frontline services for mental health, are male. Women are also 1.5 times more likely to receive any kind of mental health treatment. So that includes psychological therapy or pharmacological therapy, and that's actually after controlling for prevalence rates. Most people are kind of aware that men are more likely to take their own lives. So globally, that's the case. In the UK, it's significantly higher, with almost 4-to-1. And then also there's higher prevalence rates of alcohol misuse and drug misuse in men compared to women, which might suggest that they're using alcohol and drugs to sort of alleviate or cope with emotional difficulties. And then it was kind of mentioned that this isn't really, or it's getting more profile in the media. I would maybe argue that this is quite commonly mentioned in the media, or at least the general public are aware that this is sort of an issue, particularly around suicide in men. People are taking pictures, don't want to go through it too fast. Okay. So there's a lot of barriers men and women sort of experience, but the biggest divergence of where that kind of occurs is around this idea of masculinity and masculine stereotypes. So for the average male, they're sort of forced with these stereotypes or these narratives that they must abide to. So when you actually look at the process of asking for help, it completely contradicts these sort of narratives or arguments that they have to do. And then this is supported by the evidence. So men who have higher conformity to these stereotypes actually have worse attitudes towards engaging in help seeking or mental health services. But just as a caveat of that, just to give a more balanced argument, this is maybe too problem focused, and then with certain models or approaches like positive psychology and positive masculinity, sort of gives the idea that certain masculine stereotypes might be beneficial or adaptive when dealing with mental health. So a good example of that, unfortunately we don't have the talk later on boxing and mental health, but using exercise and sport might be a sign of self-reliance and is a good thing when you're dealing with mental health. You know, you might be more inclined to go to the gym or work out to deal with the stress you're experiencing or anxiety you're experiencing, as an example. And this is often neglected or overlooked within help-seeking literature and in solutions to address mental health in men. And then as another dimension of these stereotypes is that it can sort of contribute to more internalized stigma or self-criticism or self-blame for having mental health or having to seek support. And then this is again supported by evidence with men who endorse or have high levels of self-stigma are less likely to engage with mental health services and seek help. And then quite a widely cited review by Clement highlights that both internalized stigma and stigma of treatment or negative perceptions of treatment are the 2 biggest factors in the stigma world for deterring men to seek help. And then traditionally this has been the key focus or the target for male-focused campaigns to sort of improve awareness around mental health in men and encourage them to seek help and reduce the stigma associated with mental health and engaging with services more generally. So that's kind of just a quick overview. So then where does my review fit in and what am I trying to do? So it's quite easy to see what the barriers and what the obstacles are, but there's not really any kind of forward thinking about what might work or what the solutions could be. So the purpose of this review was to sort of summarize the interventions that have been done with men to improve help seeking, and then hopefully come out with something that's more tangible and more forward thinking in terms of how do we solve the problem. So to do this, we adhered to the PRISMA guidelines, and then we focused on keywords relating to help seeking, any kind of mental health diagnosis, any kind of intervention, and then specifically in male gender, or where they did sub-analysis of males. So we only focused on adult populations, so those over the age of 18, partly because younger boys have slightly different access to care, and they have different facilitators and different barriers, different services. And then we included both clinical populations and community populations. So in this instance, a clinical population would be men with a formal diagnosis of, as confirmed by the DSM-ICD, as long as they have a formal diagnosis, or they surpass clinical cutoffs in certain scales. So a PHQ-9 or a GAD-7 would make them eligible to take part. And then the community population is essentially everybody else. So they wouldn't need a formal diagnosis, or as part of the study, they weren't screened upon entering an intervention. Which sort of makes sense if you look at help seeking in someone's journey. You'd want to catch them ideally before they're aware they have a problem or before they have a formal diagnosis. For the interventions, we looked at any kind of design. So this is mainly to see if there's any kind of format or approach that works better than others, or certain things that don't work. And for it to be included, they have to have an outcome measure related to help seeking. So these were split into 3 key categories of help seeking behaviors. So this is probably more straightforward of attending your GP, talking to your friends, booking an appointment, attending an appointment. Help seeking attitudes. So how favorable you perceive help seeking, or what your views are of seeking support. And then your attentions. So your willingness or your likelihood of engaging with a service if you have a difficulty currently or in the future. And then the data we took from these articles was just the basic demographics, as you'd expect, and then a slightly novel thing called the behavioral change techniques, which I'm going to come to a little bit later on. So from this search strategy I've just been through, we found just under 7,000 reports, and of those 7,000 studies, only 9 managed to fit the criteria. So this is, if you need any kind of evidence that highlights the lack of stuff that's being done about how improving men's help seeking, that's probably a good frame of reference. So just a quick overview of those 9 studies. Because of our search strategy, we had really, really diverse clinical populations. So this meant we had men with like depression, PTSD, problematic drinking. There was one study looking at anorexia in men. And then also we had community samples, so men without clinical diagnoses. And then also we had really diverse interventions, as we kind of wanted, which meant some people used brochures to improve help seeking, or some people used a day workshop. One study actually used a priming task to improve help seeking. So the real question here is then, how do you make sense of it? Traditionally, you would do a systematic review of this kind of work, but when you have different populations and different interventions, you can't really summarize it because it wouldn't be applicable to any specific context or population group. So in order to do this, we used a novel approach of behavioral change techniques. So at this point, this is like really important to understand the results. So I'm going to kind of walk you through it. So the behavioral change techniques taxonomy is essentially a manual or a coding system where you highlight the active ingredients that are embedded within an intervention. So the key kind of processes or methods that are used to change behavior. So an example of this is, in a paper you might get a description of an intervention. This is just a brief example. And then you would use the taxonomy to code the techniques which are contributing to behavior change. So in this instance, this would just be self-monitoring of behavior. So yeah, that's pretty much in a nutshell. But when you have like a longer description of an intervention, this gets inherently more complex. So you can actually have multiple techniques that are embedded within one intervention, or you can have more than one technique in the same passage of text. So we actually coded this, myself and another reviewer, for all of our 9 eligible studies. And then from that, we identified 18 unique techniques that are used within help-seeking interventions for men, which contributed to improving help-seeking. So at this point, for the clinicians in the room, it's sort of, where do you go from here? Like, what do we do with this information? It doesn't really give you anything practical, which is what we were kind of stuck with. So there's all this evidence in the literature that highlights what the barriers men experience or what might improve their help seeking, but how do we then link these techniques up with the literature? And then in order to do this, we identified 7 core processes, which summarize these in more detail, which can be used in a clinical setting, which I'm just going to go through with you now. So the first process is this idea of using role models. So this can be particularly other men with depression or other men with a mental health diagnosis talking about their experience, or just male celebrities in general, which is normally quite popular within the media at least. And then the evidence might suggest that this can help normalize the help-seeking process, normalize mental health symptoms, and simultaneously reduce stigma associated with mental health and help-seeking. So that fits there. The second process was providing information about mental health symptoms or mental health diagnoses. So this fits quite neatly with the mental health literacy literature, and this idea that if you kind of are more familiar with what symptoms look like, then it's easier to detect that you've got a problem to facilitate help seeking. And again, having more higher knowledge of mental health symptoms can reduce the stigma associated with mental health generally. Thirdly, was this idea of teaching men how to recognize and manage their mental health symptoms. So this is quite similar to information, but where it differs is that this is a lot more personalized, a lot more person-centered. So you would provide individual feedback on their experiences, on their behavior, or you'd get them to sit down and do sort of a self-evaluation of their mental health experiences or their symptoms. And then again, this can improve their mental health literacy and their understanding of their experience. A few interventions used kind of techniques to manage them. So this would just be basic mindfulness or low intensity, like stress reduction workshops or just breathing. So may also contribute to help seeking. The fourth key process was delivering active problem solving. So most people, or it's definitely mentioned quite consistently in the literature, that men prefer sort of logic or rational focused or reasoning or approaches to working through their mental health. Or at the very least, men that perceive therapy where they're just going to attend and talk about their feelings, they might be less likely to engage, and that's sort of off-putting. So this might then support the idea of different frameworks might be more applicable to men, particularly motivational interviewing, certain aspects of CBT might actually encourage men to engage. The fifth process was motivating change through social support. So the taxonomy I mentioned earlier dictates that whenever motivational interviewing or CBT is used, emotional social support should be coded. So that's the main driving factor here, which again supports this idea of providing a solution-focused framework and providing motivational interviewing. The sixth process was this signposting services. So almost every intervention, I think all the interventions included like a leaflet or at least some information on who you can contact if you're experiencing emotional distress. That could be online support, professional NHS services, or even university services in a university setting. And there's some evidence to suggest that men are less familiar with just healthcare process or healthcare services in general. And this is partly to do with the idea that females are more familiar with healthcare during their reproductive years, and this might mean they have more clinical appointments for, I don't know, contraception pills or cervical screening. So that just means they're more acclimatized and familiar with the healthcare process, which sort of takes the stress and anxiety around engaging with care. So just providing men with information on how to get them to services might be more beneficial. And also, I think Roger touched on it earlier, that sort of workplace initiatives or meeting men in the workplace seem to be quite popular, and that's a good way to bridge them into traditional services through workplace initiatives, workplace training. And then the last one was this idea of positive masculinity, which I mentioned earlier. So a lot of the, as kind of mentioned, some of the target has been to shift masculinity and change the way men perceive masculinity, whereas for this is more about changing help-seeking to fit masculine stereotypes. So this would be categorizing help-seeking as a sign of strength, or encouraging men to look after themselves, and that's a responsible action that they should be engaged with. So yeah, these were the 7 key processes, which I can hope will hopefully inform clinical practice. So I'll just leave that up for a few more seconds to fully take it in, and then I'll stick it back on at the end when we're going through questions. So the benefits of this, like what the advantages of what we found is that we've identified hopefully 7 key processes, as I mentioned, which can be used in clinical frameworks and moving forward when designing future interventions for men or future strategies to engage men with services. The behavioral change techniques taxonomy is often used in health psychology and very rarely in clinical, and here it's sort of worked quite successfully. So we hope that this provides a proof of concept of how to summarize complex behavioral change interventions in a mental health setting, or just general interventions that target different behaviors. As kind of highlighted earlier when I was providing an overview of the evidence base, there's a lot of heterogeneity of the evidence base, and with the clinical populations, what interventions have been done. So I hope this provides at least some consistency, or at least a clearer overview of what's out there. Problems with this are the fact that the manual has 93 different techniques. We only found 18. So there's chances are we've missed a few, or some haven't been used, or some haven't been tested, and these actually might still be effective in men. We just don't know it. To identify the techniques is very dependent on how they're reported in a manuscript. And when you're describing an intervention, it's very rarely that you list them in the behavioral change techniques order, or in a framework that can be coded. And if there's not enough information, you simply can't code a technique. So again, this might mean we've missed a few, or some haven't been coded properly. There was actually one intervention that didn't have any techniques, but still contributed to changes in help seeking. So that's a possibility. Thirdly, men aren't all the same. As I'm sure you're aware, there's different subgroups of men, and this affects how they conform to masculine norms, how they perceive stigma, and how they perceive mental health. So certain techniques might be better for men, worse for some other subgroups of men. So it's important that we don't generalize this too far. And then lastly, as I kind of mentioned earlier, whenever motivational interviewing is used, emotional social support should be coded. Yes, techniques like motivational interviewing and CBT provide emotional social support, but a key component of motivational interviewing is to work through ambivalence. So this might actually be the idea of sitting down with men and working through the pros and cons of engaging with the service and what the benefits might be. But based on the manual, we can't actually work out if it's support or due to ambivalence. So as an overview, this is just the same figure, just reformatted. So we've identified these key techniques which might be included in future interventions and might contribute to changes in help seeking. So the idea is that then you could then use these when designing future work, and at the very least, if they don't work, we can test them more rigorously in a more profound way. And again, this can be refined. So if you want to adapt it and change it for different subgroups of men, you can test that there, and hopefully we can then move in a direction where help seeking can be improved with a scientific evidence base. And then lastly, my plan then now is to explore these within focus groups with male students to see if they come up, to see if they think these would be useful in changing their help-seeking behaviors for mental health. And lastly, this has recently been published, so about maybe 2-3 weeks ago in the American Journal of Men's Health. If you just type in improving mental health service use in men in PubMed, it should pop up quite easily. And this is gold open access, so anyone can view it. You don't have to be affiliated with an institute or pay for it, essentially. And then lastly, for a more general overview, I've co-authored a chapter with June and Luke in the handbook, which I'm sure you're all familiar with by now, which provides a more general overview of help seeking in men and how to address it. So yeah, thank you for your time, and if there's any questions.
Hi, thank you for that. This is a response partly to what you've said, but also to generally what's been going on. You started today by saying that only 36% of requests were from males, but we've also heard that we're not necessarily looking for the same outcomes. We're looking for equal opportunity there. So I don't know if we're looking for 50-50 in respect of help seeking. The point being, from my point of view, is that we perhaps need to look a little bit more on prevention than cure. Now, a lot of the strategies you're talking about would be preventative for the future for those people. But I work as a counsellor. I work with men individually, men in couples, etc. I've done that for a long time. So I'm certainly supportive of that. But if men are generally not inclined to seek help, shouldn't we all the more resource them to feel better about themselves, to have a better self-concept, to have better self-esteem? One of the things I see with men is that they have to build themselves up. And when they can't build themselves up anymore, they plummet. Now, there's a lot of men here, they may disagree with me, but that's what I see over and over. Whereas I see a lot of women bob along in this middle area a lot more. And I wonder whether that view sort of supports the idea of what's going on with male suicide, because they try so hard to keep themselves up there, and then when they can't anymore, they plummet. And I think that whole thing of men feeling good about themselves. It's okay to be me, their self-concept, what makes them successful, what counts as being an okay man or not. So much more work needs to be done on that, I think. So maybe we're not looking quite so much at we want all men to seek some mental health support. Maybe they don't need it that much if they've got the right resources in the first place.
Yeah, no, like an interesting point, and there's a lot of things that I could respond to. Just off the last point about that they maybe just need more like independent resources to manage on their own. I want to agree with you, but I feel like that just sort of going with, that's part of the problem at the moment, where majority of men feel inclined that they can manage on their own, but then that's why you're having really disproportionate suicide rates, because, or they're accessing care too late when they're too severe, and I think that's still part of the problem. And simultaneously, if you want them to have more strategies or engage with more services earlier on, how do you get them to do that in the first place? And so I hope that these processes at least identify, maybe like these could be half-day sessions or just an hour workshop or just something to give to men in a more low-intensity setting to then encourage that next step of looking for independent resources or seeking professional support. If that answers what you're saying?
Well, you know, I don't think we're actually disagreeing. I just think that there's a lot more about, I don't think men should or shouldn't be seeking support. If they're needing it, certainly they should be seeking it, but maybe at the moment men feel they shouldn't. And that may be the issue, because the ones who are needing it, as you say, are not coming forward for support. But I'm saying maybe we can resource men so not so many men are needing that support in the first place.
Yeah, yeah.
Okay, in the interest of time, I'm going to... oh, sorry, just very quickly. Yeah, very quickly.
I think I'm pretty well convinced that the message that the signpost that we give for men to come into the service, I think that's the problem. I think we really need to be looking at saying, I mean, a positive well-being program has a better, hook for somebody to come to something than a men's mental health. Any mention of mental health to a man has him run away. Anything that suggests positive outcomes has a better approach, better looking. And I love what you're putting up there, but I still think that whatever message we're getting out really needs to be something that says positive and well-being. And because they're not feeling well, and they're not feeling positive, and it's saying to them, I know that this is happening. Come, we have this to offer you. Do you understand what I mean?
Yeah, no, completely. And
yeah.
I think I agree with what you're saying in the sense that we should advertise and how we promote these interventions or strategies or even traditional services should have a more of a positive connotation, or something that's less perceived as less damaging to one's identity or masculinity.
Right. Or even goes with the grain of it.
Yeah, but the only caveat to that is I wanted to chuck out there is this is kind of being done, and some of the newer phrases, a classic one is Man Up Monday. And what it's actually doing is you have to be careful not to reinforce traditional masculine stereotypes, because then what you're actually doing is you might get more men engaged, but over the long term, they might have worse outcomes. So it's something really careful that you have to be considerate of when designing or labeling mental health interventions in a way that's more...
I definitely don't like the Man Up one. I think it's not fair.
It won awards for the way it promoted itself, but evidently, yeah.
Much to discuss and reflect on. We have to have no more questions.